you hear me? Can you hear me?
Madam, very well.
Okay. See, first we'll talk about classification of breathing systems. Breathing systems are classified into open breathing system, semi-open, semi-closed, and closed. So let us see what does this open and closed means. Open breathing system is where the respiratory tract of the patient has an access to atmospheric air during both inhalation and exhalation. There is no reservoir and hence no rebreathing. The examples are handkerchief with chloroform placed close to the patient's nose, or an open ether mask, Schimmelbusch mask, held away from the patient's face. Why away from the patient's face? So that the ether gets vaporized, the room air vaporizes the ether, but there is no reservoir through which the patient breathes. Patient breathes the room air. This here is a Schimmelbusch mask. This is a frame over which we put gauze pieces. Now the question asked in the exam is how many layers of gauze pieces to be put? The answer is you should see the rays of the light coming through it. That is, so generally it is about 8 to 10 layers of gauze pieces. And you have to change every time you are using for every patient because it is a source of infection. Now, I'm not going into details of how to do open ether anesthesia, it will be too much. But if this mask is held away from the patient's face, that means it is not touching the face of the patient, but close to the nose, you call it open system. The moment you put it on the face, like any other face mask, then you call it semi-open breathing system. So now what is semi-open breathing system? The patient's respiratory system is open both during inhalation and exhalation to the atmosphere through a reservoir or a breathing system. So Schimmelbusch mask becomes a reservoir through which the patient breathes if the mask is closed to the patient's face. Rebreathing is technically absent and atmospheric air either carries or dilutes the anesthetic gas. Examples are open ether mask held in close proximity to the face or Oxford inflating bellows with draw over vaporizer, or ISTP system with no expiratory limb or expiratory limb capacity much less than the tidal volume of the patient, where air dilution occurs. I think we all know that air dilution occurs in TPs if your flow rate is less, if your expiratory limb is lesser capacity or no expiratory limb. And all the resuscitation equipments, they are semi-open breathing systems. Here are the examples of semi-open breathing systems. You can see ISTPs. If you remove this expiratory limb or the capacity of the expiratory limb is less than the tidal volume of the patient, then please remember it becomes a semi-open only in spontaneous breathing. Because in controlled breathing, even if your fresh gas flow is less, you cannot ventilate the patient. You have to increase the flow. So in controlled breathing, it can never become semi-open. Only on spontaneous breathing, it can become semi-open. All your patients who are on TPs with oxygen, they all draw in room air. So it becomes a semi-open breathing system. We were using bellows, okay, with EMO. This is Epstein-McIntosh Oxford vaporizer used for ether. That day I was discussing what should be in the center, the bellows or the vaporizer. So you can see here, bellows is in the center, so the vaporizer you can remove and re-put it, which is very convenient. So here room air is drawn in during inhalation and exhalation, of course, it goes out. Okay, so it's a semi-open because room air has to enter through this circuit. It cannot directly enter the patient. Here are your reservoir, your resuscitation bags. Here we have connected Goldman to bellows. Again, this is a semi-open breathing system. So these are the examples of semi-open breathing system. Now, what is a semi-closed breathing system? Please remember, whatever we use in anesthesia, most of them are semi-closed breathing systems. A semi-closed system where the patient's respiratory system has absolutely no access to atmosphere during inhalation, but partly or fully open to atmosphere during exhalation through the breathing system. Examples are all Mapleson rebreathing systems. Mapleson system with non-rebreathing valve. Please remember some of the students, whenever they are giving valve, NRV, they say Mapleson system is a semi-open. It is not. It is still semi-closed because gases have to enter through the system, through the Boyle's machine and the circuit. Gases cannot enter from atmosphere. So open word is out. It is still semi-closed. Only thing, there is no rebreathing. Circle absorber with APL valve allowing venting of gases. because gases do enter atmosphere, so it becomes semi-closed. And water's to and fro system. So here are the examples of Mappleson's breathing system or semi-closed breathing systems. So Mapleson A, B, C, D, E, F, all are semi-closed breathing system. If you are using Meigels or not, that is a non-rebreathing valve with Meigels system, that is Mapleson A, it becomes a semi-closed. And water's to and fro is a semi-closed system. Closed breathing system. Closed breathing system is the one where there is no access to atmosphere either during inhalation or exhalation. No escape of anesthetic gases is allowed. That means circle system with APL valve totally closed. So this system, when you use, you are using a closed system with basal flow rates. That is just 250 ml of oxygen. So that is called closed, and we hardly use it. We always use it with low flow, and then it becomes a semi-closed system. Here is an example of semi-closed or closed. Means this is the only system where you close the APL valve, it becomes a closed system. Otherwise, it is semi-closed. Now remember the parts of the breathing system. We'll discuss something about reservoir bag, which is kept in the exam sometime, and a breathing tubes they keep in the exam. So let us see how they work. You can just take a snapshot of the slide, or maybe your Dr. Kalpana may give you this. I have discussed in short what is open, semi-closed, their definitions. So I'll just go over it. You can take a snapshot or you can ask Kalpana madam, she'll give you. Let us look at reservoir bag. The sizes available are 0.25 liter to 6 liters. What is the ideal capacity? Ideal capacity is equal to vital capacity. I mean, ideally. But what we commonly use is 3 times the tidal volume. Why 3 times the tidal volume? Because if you use equal to tidal volume, then patient while coughing, straining, lighter level of anesthesia will not get enough gases. If you use equal to vital capacity, what will happen? A large bag, it is difficult to monitor during spontaneous breathing because excursions are small. And it is difficult to squeeze during controlled ventilation because you will hardly get a satisfaction of squeezing the bag. There will be a lot of resistance if you are using a larger capacity bag. So ideal is vital, but we use 3 times the tidal volume and we are comfortable with that. Types, it may be closed and double and Coons bag. Composition, it may be rubber, plastic, latex or neoprene, but the shape is always ellipsoidal. What are the functions of reservoir bag? If you are given reservoir bag in your hand, then you have to say it acts as a reservoir so that it reduces fresh gas flow requirement. Because if there is no reservoir bag, then we will require our fresh gas flow equal to peak inspiratory flow rate of the patient. So in short, it provides peak inspiratory flow rate. It protects the patient from excessive pressure in the breathing system. Why? Because the breathing system is such, the reservoir bag is such that a pressure cannot develop beyond a certain limit. And if it develops due to any obstruction, the bag will burst. So this is how it protects the patient from excessive pressure. It can serve as a monitor for patient's spontaneous respiration through visual and tactile observation. It provides a means whereby ventilation may be assisted or controlled. And it can give the operator a feel of resistance offered by patient's airway or lung during manually controlled ventilation. So that way it helps you whether airway resistance is higher. Now there's something called collapsing pressure of a reservoir bag. By definition, it is a minimum amount of pressure that keeps the bag distended. Collapsing pressure depends on the type or characteristic of the bag and cannot be changed. Opening pressure of an APL valve, pop-off valve, let us say, or head-ring valve, should always be higher than the collapsing pressure of the bag. So one has to adjust the opening pressure of an APL valve or a pop-off valve because collapsing pressure is fixed. By adjusting that, you will see that the bag remains to its fullest extent. If you, for example, if you invert the head-ring valve while in use, the bag will not distend fully as the valve remains open all throughout. So this is the point to be remembered. Now breathing tubes, let us say if you are given a breathing tube in your hand, what will you say? They are made up of rubber or plastic or silicone. They can be impregnated with carbon to make it anti-static or impregnated with silver to add an antimicrobial effect. Corrugations will prevent kinking and increase flexibility. Length is variable, but usual length is 42 inches or 110 centimeters. Internal diameter for adults is supposed to be 22 millimeter and for pediatric 15 millimeter. Internal volume is supposed to be 400 to 500 ml per meter length of the tube. The distensibility should be 0 to 5 ml per meter per millimeter of mercury pressure. The resistance to gas flow should be less than 1 millimeter of water per liter per minute of flow. And please remember, antistatic material is a good conductor of electricity. It does not allow static charges to be accumulated on it. Now there is something called backlash effect. What is it? During spontaneous ventilation, breathing tubes tend to collapse on inhalation and bulge on exhalation. This is called backlash effect and it leads to rebreathing. So please remember, backlash leads to rebreathing. Then there is something called wasted ventilation. This happens on controlled ventilation or assisted ventilation. Breathing tubes tend to bulge on positive pressure breath, that is inspiration, and return to resting position or exhalation. So this is called wasted ventilation. So less volume entering the patient than the one leaving the reservoir bag or a ventilator. And hence it is called wasted ventilation. Now here is your head ring valve. The parts are screw cap, spring, disc, and the housing. The disc remains here on the seat. With the help of the spring, it is always, the spring, and with screw cap, you compress it. Okay, so valve is invariably closed. It is only during exhalation when the patient is circuited, the valve opens. Yeah, anything else? Hello? Now, opening pressure of the valve is 1 to 2 centimeters of water, which is higher than the collapsing pressure of the reservoir bag. In case your spring is lax and not working, you might have to screw it in so that you increase the opening pressure of the valve. Otherwise, your bag will always remain collapsed. Now, depending on the fresh gas entry port and the reservoir for gases, Mapleson systems are classified into Mapleson A, B, C, D, E, F. Mapleson systems are all semi-closed breathing systems. Now, Miller has classified them into afferent and efferent system. So afferent limb is that part of the breathing system which delivers the fresh gas from machine to the patient. If the reservoir is placed in this limb, as in Mapleson A, B, C, and lax system, they are called as afferent reservoir system. Efferent limb is that limb of the breathing system which carries the exhaled gases from the patient and vents it to atmosphere through the expiratory valve of the port. So if the reservoir is placed in this limb, like Mapleson D, E, and F, then they are called efferent reservoir system. So here is an example. Can you see here A, B, C? These are afferent reservoir system, and D, E, F, they are efferent reservoir system. For example, you can see here APL of pop-off valve is located close to the patient. Okay, but reservoir is in the afferent limb. Here exhaled gases occur, so reservoir is in the efferent limb, and that's why they are called efferent reservoir system. And these are generally a T-piece type arrangement system, leaving the circuit at a distance from the patient. You can take a snapshot of this because this is just in short, what is the location of fresh gas for the system, valve location, reservoir bag, whether there or not there, corrugated ribbon, and examples and comment about the system. So you can take a snapshot of this slide, which will help you when you appear for the exam. Now, Mapleson A, let us discuss what is it. So during spontaneous ventilation, a fresh gas flow equivalent to alveolar ventilation or 70% of the minute ventilation, because alveolar ventilation is generally 70% of the minute ventilation, which is required to prevent rebreathing. A flow of about 5 liters per minute is required in young healthy patients to flush out the system of CO2. Fresh gas flow rate of 3 times the estimated minute ventilation is required for controlled ventilation. Very inefficient system if controlled ventilation has to be done with that. A waste gas scavenging is difficult because the APL valve is close to the patient, and hence scavenging becomes difficult in this. You can use this with non-rebreathing valve. It is still a semi-closed system, but where there is no rebreathing. You cannot give 70% of minute ventilation. You have to give minute ventilation equal to the patient's minute ventilation. So that is the point to be remembered. Now, coaxial Mapleson A breathing system. Here what happens? Exactly opposite of your vein system. The inner tube is an efferent limb and the outer tube is efferent limb. That means outer tube carries gases to the patient and inner tube carries exhale gases. It is a modification of Mapleson. Patient breathes through concentric tubes where outer tube, which is efferent limb, 30 millimeter in diameter, is inspiratory, and inner tube, which is an efferent limb, 14 millimeter in diameter, is expiratory. The valve is moved to the machine end of the system, and hence you can connect a scavenging system to this. So how to make Mapleson A feasible for scavenging? So it is coaxial modification of Mapleson, which is called LEX system. Now, important point, whenever there is inner tube and outer tube, you must know integrity of the inner tube. So how to test this or test that? So you attach an endotracheal tube to the inner tube. That means you remove this mask. To the inner tube, you attach an endotracheal tube with your connector. Then close the APL valve and blow through the endotracheal tube. Now you are blowing through endotracheal tube. Okay, your APL valve is closed. So if the tube is damaged, then the bag will move. Okay. Another way is obstruct both the tubes, means the inner and the outer tube. With APL valve open, squeeze the bag. If the inner tube is damaged, the gas will escape through APL valve. So these are the two ways of testing integrity of the inner tube in LEX system. Now, there are enclosed efferent reservoir system. However, I have never seen them. I have only seen them in the figure or in the book. But you must know that they are described by Miller and Miller. And the advantage is that it is more efficient than Bates system when fresh gas flow is more than or equal to alveolar ventilation. So these are enclosed efferent reservoir systems. Now let us see coaxial Mapleson D. Because Mapleson D we have hardly used. We are using it only in the form of Bain circuit. So this is called coaxial Mapleson D or a Bain system. Fresh gas enters the inner tube, exactly opposite of your LEX circuit, which is a small bore tube. Exhale gas is carried via the outer tube. Spontaneous ventilation, fresh gas flow of 2.5 to 3 times the minute volume is required to prevent rebreathing, or in short, 200 to 300 ml per kg. Control ventilation, fresh gas flow of 70 ml per kg per minute results in normocapnia, provided minute ventilation is adequate. 120 ml per kg per minute in patients more than 40 kg. Now this charts you must be seeing in the book. You can see here that you can maintain the PCO2 of 28, 32, 38, 42. Constantly, your minute ventilation is changing, right? Can you see minute ventilation, say from 160 to 260 ml per kg per body weight? You can maintain it at 28, provided your fresh gas flow is 100 liters. If the fresh gas flow is between 80 and 100, you can maintain it at 32 with minute ventilation of 140 to 260 ml per kg per minute. So this chart says that everything varies depending on fresh gas flow rate and minute ventilation. So what is the relation? So important factors are fresh gas flow rate, respiratory rate, tidal volume, because this will decide your minute ventilation, and the expiratory pause. Expiratory pause is most important here. So what happens? The factors that increase the rebreathing are decreased fresh gas flow rate, decreased duration of expiratory pause, increased respiratory rate, and increase in tidal volume. So these things will affect your rebreathing and increase CO2 production. Of course, CO2 production is increased. You have to change your fresh gas flow rate, minute ventilation, everything. Bain system, ETCO2 depends on fresh gas flow if minute volume is more than fresh gas flow. And it depends on minute volume if fresh gas flow is more than minute. So these factors to be remembered. With lower fresh gas flow and high minute volume, conservation of heat and humidity occurs, economy of gases, and no hypo or hypercarbia. Recommendation by Bain and Parel, who invented this circuit, are 2 liters per minute fresh gas flow in patients less than 10 kg, 3.5 liters per minute fresh gas flow in patients between 10 to 50 kg, 70 ml per minute in patients more than 60 kg, tidal volume to be set at 10 ml per kg, and respiratory rate 12 to 16 breaths per minute. This is what is the recommendation for using Bain circuit. Now let us see advantages of vein circuit. Lightweight and convenient, easily sterilized. This is if you are using a non-disposal circuit. Scavenging of gases from expiratory valve is facilitated because the valve is located away from the patient. Exhale gases in outer reservoir tubing add warmth to the inspired fresh gases. Hazards: unrecognized disconnection of inner fresh gas hose leading to hypercarbia. Kinking of fresh gas hose leading to increased respiratory resistance. Now let us see how do you test the inner tube, integrity of the inner tube. So there are two tests. One is called Pethick's test. Fill the reservoir bag while holding a hand over the patient port. Patient port means both inner and outer tube. Once the bag is filled, remove the hand and at the same time activate the oxygen flush. Now what is happening? That the inner tube will carry the gases, correct? It's a thin diameter. You are suddenly removing your hand and activating the flush. That means you are creating a Venturi effect. Observe the bag, whether it deflates. If the inner tube is intact and correctly assembled, the reservoir bag should deflate because of Venturi effect is created. So a Venturi effect created by the oxygen flow from the inner tube will cause a negative pressure in the exhalation tubing, and this will cause the bag to deflate. However, if the inner tube is not intact, this maneuver will cause a bag to inflate slightly. But please remember, this test would not expose the faulty vein system where the inner tube is omitted or the inner tube does not extend up to the patient's port. So then there is another test. Okay, how do you confirm this and how do you do this test? Turn on the flow meter, occlude the inner tube with a finger or a plunger of a 2 ml syringe. Here, occlude this tube. Okay, observe the flow meter indicator. Remember, your flow meter is on. Okay. If the inner tube is intact and correctly assembled, the flow meter indicator will fall due to rise in gas pressure within the inner tube up to the flow meter block. Because you are supplying gases and you have blocked this. So there will be a back pressure in the flow meter. So this is the test which will test everything. Integrity of inner tube and whether inner tube is there or not there. Because if it is not there, you cannot connect your plunger or your hand to that. Now, TPs. We are all aware and we are using this often. I don't know whether you all are using IS TPs now because it is gone. We were using, okay, and they were looking like this. There were two sizes, adult size and pediatric size. And this is how we were connecting, okay. This is your fresh gas flow, okay. Expiratory limb, you can see it is larger than the capacity of the child's tidal volume. Now Harrison modified this as type 1, type 2, type 3. Type 1 is no expiratory limb, means no reservoir at all. Type 2, volume of expiratory limb greater than the patient's tidal volume, what you are seeing here. And type 3 is volume of expiratory limb lesser than the patient's tidal volume. Most useful is type 2, that is volume of expiratory limb greater than the patient's tidal volume. Because this will, well, little rebreathing can occur, but not so much. But whatever you are supplying, patient will get. Here, air dilation will occur, type 1 and type 3, and it gets converted into your semi-open system. So Mapleson E system, valveless TPs arrangement. Modification of IR's original TPs with addition of corrugated tubing to the expiratory limb, which becomes a reservoir for fresh gas. Now, original IS TPs has no corrugated limb attached. This is a modification of original IS TPs. It is used initially for pediatric patients undergoing palate repair and intracranial surgery. Minimal dead space, no walls, hence very less resistance. Volume of expiratory limb more than patient's tidal volume to prevent air dilution on spontaneous breathing. Control ventilation is achieved with a mechanical thumb ventilator or intermittent occlusion of expiratory limb. Now here you may either avoid totally the expiratory limb or you may keep it lesser than the patient's tidal volume. Approximately 3 times the minute volume is required to prevent rebreathing. Mapleson E ISTPs, here you can see how it looks. During control ventilation, feel of the bag is not there and hence hazard of barotrauma is a possibility. Difficulty in scavenging the system. Commonly used to administer oxygen or humidified gases to intubated patients breathing spontaneously in recovery room or in ICU. And there are numerous modifications of TPs. You must have seen latest TPs which are of plastic origin. There are various designs available. Now what is Jackson Rees, which is called Mapleson F system. TPs arrangement with a reservoir bag. Relief mechanism is either an adjustable valve at the end of the bag or hole on the side of the bag. For example, you can see here, it is open-ended. Newer modification incorporates an APL valve before the reservoir bag. You can see here. Next slide, I'll show you that. Pressure relief is actuated at 30 centimeters of water in that valve. Fresh gas flow 2 to 3 times the minute volume for spontaneous respiration. Fresh gas flow equal to Baines for controlled respiration. Hazards: lack of humidification, need for high fresh gas flows, occlusion of relief valve can increase the airway pressure and can produce barotrauma. Now, here is the Mapleson F with APL valve. You can see here, this is the latest arrangement, 1998 it came. Intersurgical decided to modify the Jackson bridge by using a closed tail bag. This bag is closed tail, it is not open. A specially modified APL valve is used. With APL valve, the waste gases can be removed safely from the system via the APL valve 30 millimeter outlet. Here is the outlet. So you can use it for scavenging. Now there's something called Humphrey ADE system. I have not used, but typical example is given, and I don't think anybody has it. The things to be remembered are that it is designed by Humphrey D. and Brock. It has two reservoirs, afferent and efferent. Okay, you can see here two reservoirs. You can use it as A, D, or E. Depending on which port you use at fresh gas flow, whether you are closing the valve, whether you are keeping the valve open, and whether you're connecting the bag or keeping it open, whether you're connecting bag, afferent limb, or no bag. Okay. So this is no bag is E, Mapleson D is efferent limb, and Mapleson A is bag connected to afferent limb. So you can use this as A, D, or E, any system that you want. Now Mapleson breathing system A to F. A, B, and C, APL valve is located close to the patient. D, E, and F, these are TPS arrangements with gas leaving the circuit at a distance from the patient. Potential exists for the patient to inhale alveolar gas that has been previously exhaled and contains CO2. Extent of rebreathing depends on patient's minute ventilation, pattern of ventilation, fresh gas flow rate, and whether ventilation is spontaneous or controlled. This is combination of A, B, C, D, E, F I am talking. Dead space in the breathing system. It is volume of the breathing system from the patient and to the patient, the point up to which to and fro movement of expired gases takes place. That is up to expiratory valve, point of fresh gas entry, or point of bifurcation of breathing tubes, depending on the type of circuit. So here, you can see here, expiratory valve, Mapleson A. So up to here is the dead space. This is your T-piece. Fresh gas is entering here, so up to here is the dead space. And if you are using a Y-piece in a closed circuit, then dead space is up to here. So this is the point to be remembered. Now here is a chart, spontaneous mode, control mode, Mapleson A, B, C, D, E, F. I have given you the flow rate required to prevent rebreathing in both the system. Okay, the merit for spontaneous is A is best, B is worst. Control mode, D is best, and A is worst. So this is a sequence in which you can say the merit of the circuit. The point to remember, okay, here are the uses. Okay, Mapleson A, B, C, D, E, F. You see B is hardly used. C is used only for resuscitation. D, we are using in the form of base circuit. A, we are still using, and we are using Jackson bridge. TPC is only for ward purposes, for giving oxygen. Now, relative merit, how do you remember? During spontaneous ventilation, A is better, most efficient, B is worst. Okay, B is worst. So A, D, F, E, C, B. So it is remembered as all dogs can bite spontaneously. Okay, so this is all dogs can bite. This is the merit. For controlled ventilation, dog bites can be ache after the situation is controlled. So this is how you remember the merit of Mapleson ABC. Mapleson A is most efficient during spontaneous, but worst for control. And D is most efficient during control, but not for spontaneous. So this is your Mapleson systems. Okay, what are the advantages? Simple and inexpensive. Components can be easily disassembled and reassembled, can be sterilized. System provides buffering effect so that variations in minute volume affect and tidal CO2 less than a circle system. Rebreathing will result in retention of heat and moisture. Resistance is within the recommended ranges. Lightweight and not bulky. Systems do not cause excessive drag on the endotracheal tube. Easy to position conveniently. Compression and compliance losses are less with these systems than the circle system. And changes in fresh gas concentration result in rapid changes in inspirated gas. These are all the advantages over circle system. Disadvantages are require high gas flows, higher cost, increased atmospheric pollution. Optimal fresh gas flow may be difficult to determine because this is different for every system. Necessary to change fresh gas flows when changing from spontaneous to controlled mode. Anything that causes decreased fresh gas flow can produce dangerous rebreathing. In Mapleson A, B, and C system, the APL valve is close to the patient and may be inaccessible. E and F are difficult to scavenge, and these are not suitable for patients with malignant hyperthermia because it may not be possible to increase the fresh gas flow enough to remove the increased CO2 load. Non-rebreathing valves. Now let us see whenever we use non-rebreathing valve with McGill circuit, that is Mapleson A. What are the importance of it? It is useful in resuscitation equipment, any non-rebreathing valve. Pediatric cases or remote areas where CO2 absorption is not available, non-rebreathing valves are used. What you must know about the valve, whenever you are given a valve in your hand, there are lots of valves and probably you all have not used it, but we have used in our practice. So there is a valve body assembly. It is a housing with associated internal parts. There is a valve body. It is a housing for valve body assembly. A valve seat or a sitting. It is a surface with a partially or completely obstructed opening. A valve inlet. Fresh gas enters through valve inlet. Patient port, which is connected to the patient. And the exhalation port. It is a channel through which the exhaled gases escape. Parts of the valve body, well, I described this in detail. Okay, let us see here. These are the valves. You can see here Rubin valve, two varieties. Here is a Rambo valve. This is called Aga Poly valve. This is Lewis Lee valve, the original. Here it is modified. The patient port here is coaxial, whereas here it is at a right angle. So both are Lewis Lee valve. Now, where do we use non-rebreathing valves? We use it for resuscitation, obviously you all know it. Certain ventilators used. For example, this ventilator has a Aga Poly valve, this ventilator has a Rubin valve. Here I am using anesthesia, say semi-open circuit with EMO. Can you see here my resuscitation bag is here, but my valve I have placed here near the patient. So I can use it for remote area where CO2 absorption is not available. I can use non-rebreathing valve and give anesthesia and avoid CO2. Okay. Now, classification. How do you classify them? So depending on the mechanism of working, you call them positional valve, non-positional. Depending on the movable part, you call it flat type, fish mouth type, disc type, mushroom type, spring type, magnet type. And depending on the function, you say whether it is designed for spontaneous breathing, controlled breathing, or you can use for both spontaneous and controlled breathing. So whenever you talk about it, you start like that, whether it's a positional valve, what type of valve? Say you are given a Lardell valve, you must call it fish type valve. Okay. Mushroom type, you may call it Ambu valve. Spring type, magnet type, you are given a Mitchell valve. And whether you can use it for spontaneous breathing or control. Now, for example, these are movable parts. Can you see here? There is a disc here. Okay. So whenever inspiration occurs, the disc goes and blocks the expiratory channel. This comes back because there is a spring here. Okay. So this comes back and patient can exhale to atmosphere. This is Rubin's valve, which has got something called yarn spool or a bobbin and a spring. So the spring keeps this bobbin this way. Okay. So no inhalation can occur. When patient wants to breathe, okay. For example, when you compress the bag, the bobbin is moved here, gases go to the patient. Then because of the spring action, the bobbin comes back and patient can exhale. So this you will see in Rubin's valve. Here is Mitchell valve, which has a magnet. Similar poles face each other. So the magnet always remains in this position. Whenever you want patient to breathe, please remember this valve, you have to overcome the force of this what to say, this force oppose each other. So unless you overcome the opposing force and move the magnet towards the valve, expiratory port, you cannot ventilate the patient. So this is always called a Mitchell inflating valve. That means this valve can be used only for controlled breathing and not for spontaneous breathing. Here is your typical AMBU valve, okay, which has got silicone flaps. And I think all of you must have seen it, okay. Silicone flaps allow you to, I'll show you in the next slide. And silicone flaps, they look like this sometimes, and sometimes they are just like this, okay. So this is a different design of those silicone flaps. Here is a lardel valve, which is called fish mouth. Can anybody tell me something about this lardel valve? If you are given in the exam, how will you answer? Anyone?
Ma'am, this is a non-breathing valve. It is made up of plastic material. It is lightweight. It is transparent. It has a fish mouth valve, which is for inspiration, and a circular shaped flange, which is for the expiration. It is used for both spontaneous and controlled ventilation. And the dead space is also very less in this. 7.
Okay. Yeah. Yes. Can it be sterilized?
Yes, ma'am, it can be sterilized. Yes.
It is reusable. Yeah, yes. It is not disposable. Reusable, yes. Can be sterilized. Okay. How do you sterilize it? It is asked in the exam. So you must be prepared for that. Okay. You cannot put it in an autoclave.
Yes.
Okay. You may either do your ethylene oxide sterilization, or you may put it in the Sidex. Okay. But if you put it in the Sidex, you have to wash it thoroughly. Otherwise, it can enter the patient's lungs. Okay. If you do not wash that Sidex properly. So that is to be remembered. Okay. Here are different varieties of AMBU valve.
Dead space.
Yeah,
yes, ma'am.
She said dead space.
She said that.
Dead space is 7. Yes, ma'am. I said.
Okay. See, here I told you how AMBU valves look like. Here is a flap, silicone flap. Can you see the flap can move? Here is a mushroom disc, So this is again an AMBU valve. So you can see flap here. Okay, this is most important. This is AMBU valve, which is little bigger size. It's called ESI-PGIMSR valve. ESI-PGIMSR. It is used only for resuscitation. Please remember, it does not have an expiratory flap. So you cannot use for spontaneous breathing because atmospheric air will enter the patient. So it is used only for controlled breathing, ESI-PGIMSR, okay? And not for spontaneous breathing. Now here, these serrations are there. Here there is nothing. So this can easily get blocked. Supposing you are given this valve. So you can say that the disadvantage is that it can block, that expiratory port can get blocked with the drapes. If it is under the drapes. Here, even if it is blocked, this, can you see those, this thing, they allow here, okay? Here they'll not allow. So depending on which valve you are given, you can talk about it, okay? This is Rubin valve. I told you this is called yarn spool, okay? And here is a spring. How does it open? The yarn spool moves here, inhalation occurs, okay? Then it comes back here, blocks the inspiratory port, so exhalation can occur. This valve can be used for both spontaneous and controlled breathing, okay? Then there's something called forward leak and backward leak. Now I'll tell you what is forward leak. Whenever you are ventilating a patient using a non-rebreathing valve, if your tidal volume leaks out from the expiratory limb, that means partly it goes to the patient and partly out, it is called forward leak. So forward leak will happen if this flap does not close the expiratory port completely during inspiration, okay? What is backward leak? If this does not close this portion, then what will happen? During exhalation, most of the gases will go out, but part of them can go back. Because if this is incompetent, so that is called backward leak. And every valve has a forward leak and a backward leak. You must know the importance of forward and backward leak. Here is a Mitchell valve. I explained you how these two similar ports face each other. So valve is in such a position that if you want to ventilate, you have to apply positive pressure. Only then you can ventilate. Hence, this valve is called an inflating valve, meaning it can be used only for controlled ventilation, not for spontaneous. Lewis, this is the best valve. Why? Because, see, can you see this flap? The flap can completely align with the expiratory port, or it may not align depending on whether you are moving. This is screw thumb. You can move it so that you are not allowing this to get aligned properly, or you can move it in such a way that it can align properly. Now, what is the advantage of that? that if this aligns properly, that means during inspiration, no forward leak, correct? No gases can go out. But when will you keep it in such a way that you are not aligning it whenever you're using for spontaneous breathing? Because spontaneous breathing, patient's inspiratory effort will draw in gases, right? So there is no question of gases going out. During exhalation, the flap will always come back. Exhalation will occur. But in case your flow rate is higher than required for a spontaneous breathing, let us say patient requires spontaneous breathing flow rate of 5 liters per minute. But you have kept a flow rate of 6 liters because in case coughing occurs, patient becomes light, he should get higher flow rate. Now, what will happen if you are using a non-rebreathing valve? Whenever your flow rate is higher than required, the bag will keep on inflating with successive breathing. And what will happen? The flap valve will go and block the expiratory port because there is high pressure. In such a case, barotrauma can occur. So if you are using this valve for spontaneous breathing, keep it in such a way that this alignment is not proper. So if there is excess flow rate, okay, it can leak out from here because alignment is not proper. So this flap cannot block the expiratory port completely, which is not possible in your AMBU valve, in your other valves. So this has an advantage of that. This is AGA poly valve. Now this valve came with this ventilator. Okay. Now what is the advantage of this valve? This is a port. Okay. There are 3 ports: fresh gas flow port, patient port, and exhalation port. But there is one excess port. So this is the port which will allow room air to be entered in. So if you want to use it on this ventilator, let us say the ventilator can draw in room air. Okay, when the ventilator bellows come up, and during exhalation, this is closed. Okay, air entering in port, and patient can get ventilated. So this is the advantage of this valve. This is called AGA poly valve. You can use it with air dilution. You can use without air dilution. You can use for spontaneous. You can use for control, and that's why the name poly. Now, how do you evaluate a non-rebreathing valve? So you must know the dead space. You must know inspiratory resistance, expiratory resistance, forward leak, backward leak. Now, what is backward leak? You can have a control over backward leak, not forward leak. If there is rapid release of bag, means you are controlling the patient's respiration, you rapidly release it, or you release very slowly. If you rapidly release, the backward leak is less. If you release very slowly, then backward leak may be more. Okay, so release of the bag will decide how much is the backward. Now this table, you can take a snapshot of this. I have told you everything about AMBU valves, AMBU E, E2, AMBU Hess, Fink, Fumin, Lardell, Lewis Lee, Ruben, Stephen Setter. So what is the dead space? What is inspiratory resistance, expiratory resistance, back leak, quick release, and back leak retardant? So you can take a snapshot of this. In short, this will describe all the valves. If you master this, you can answer in the exam whichever valve is given. Now, what are the advantages of a non-rebreathing valve? It's an inexpensive, light, compact, and mobile system. It's a simple system with minimum number of parts and minimum alveolar dead space. The system can be used for spontaneous, assisted, or controlled breathing without changing any assembly of the equipment. There is no rebreathing and hence no chances of hypercarbia unless the patient hypoventilates on spontaneous breathing because he is in the deeper plane of anesthesia. Inspired concentration of gases and vapors is close to what you have set. The exact minute volume of the spontaneously breathing patient can be known. Okay, how will you know it? During stable state of maintenance of anesthesia, the total flow set on the flow meter is the minute volume of a spontaneously breathing patient. Then the reservoir bag neither collapses nor distances successive breaths. This is what I explained you. That if the two matches, no problem, it is good. But if your minute volume is a little higher, the bag will go on inflating, and the pressure in the circuit will build, and the expiratory port gets closed, and that is how patient can get barotrauma. So this has to be kept in mind. The only 2 distensible parts of the system are the patient's lungs and the reservoir bag. Therefore, the feel of the bag may be a better indicator of changes in compliance than the system employing relief or pop-off valves. So if you do not employ relief or pop-off valve, you will know the compliance of the system. Since there is no rebreathing, exhale gases do not enter the breathing system except the body of the valve and the exhalation pathway of the valve. And therefore, sterilization of the NRV alone instead of the entire circuit may suffice at times in emergency situation. So this is the advantage if you're going to use an NR. Now, non-rebreathing system, if you're going to use with vehicle system, not a very popular system because it is not economical as high fresh gas flow is required. There is no humidification of inspired gases. There is no conservation of heat. The valves can malfunction due to condensation of moisture and lead to complications. They are not convenient as the bulk of the valve has to be positioned near the patient. And fresh gas flow needs to be constantly adjusted, especially during initial induction phases and emergence phases if your patient is on spontaneous breathing, because either the bag will keep on deflating or the bag will keep on inflating. If fresh gas flow is less than the minute volume during spontaneous breathing, the reservoir bag keeps collapsing with successive breaths and patient may starve of gases. And if it is higher than the minute volume fresh gas flow, then the bag gets overinflated and may give rise to barotrauma. This can be taken care of by providing a spill valve during spontaneous breathing, which needs to be closed during controlled breathing. So in conclusion, Mapleson system used for spontaneous breathing during induction and for short cases under mass, Mapleson A. C is used for resuscitation or for spontaneous breathing during induction. D is used for controlled ventilation when ventilator not available. E is used for oxygenation in ICU and PSCU. F is used for pediatric cases when ventilator is not available. Present day breathing system of choice is circle absorber with low flows and disposable tubing and Bain system. Now that day I was telling you about inlet and outlet. Okay. Now can you see here? This says inlet. So if I disconnect this tube, put my finger inside index finger, it will go right up to here because this is the inlet. Okay. But if I put my tube here, this will obstruct me because this is outlet of the valve. Okay. So I will know which is inlet and which is outlet just by putting my finger inside. Here is your a different system where inlet is here and outlet is here. Again, same way you can confirm which is inlet and which is outlet. I told you apparatus dead space in a Y piece of a circle system is up to what? Okay, it is up to this point. Here is your VOC and VIC. Okay, so this is VIC in expiratory limb, VIC in inspiratory limb. Okay, and here I am using a vaporizer on the back bar of the machine. So this is called VOC. Advantages of a circle system: economy, humidification, reduction of heat and loss, reduction in atmospheric pollution, control of breathing, ease of monitoring oxygen consumption, and gases enclosed, so less chances of explosion. Disadvantages: it's a cumbersome and heavy system, leak prone as multiple connections, increased resistance, heat from soda lime may increase body temperature, alkaline dust may pass and affect the body, cross infection can occur if you're not sterilizing it properly. But important considerations in circle system are: what should be the fresh gas requirement? What is the dead space? So breathing tube length does not affect dead space. Please remember, apparatus dead space is limited to the area distal to the point where inspiratory and expiratory gas mixing occurs at Y piece, which I showed you in the slide. Resistance: unidirectional valves and absorber increase the circle system resistance at high respiratory rate and larger turnover. Humidity and heat conservation: heat and humidity of inspired gas depends on the relative proportion of rebreathed gas to fresh gas, and absorbent granules is a significant source of heat and moisture in the circle system. Bacterial contamination: risk of microorganism retention in circle system component. Respiratory infections in subsequent patient. Bacterial filters are incorporated into the breathing tubes or at the Y piece may. How do you optimize the circle system design? Unidirectional valve: they should be as close to the patient as possible, okay, to prevent backflow into inspiratory limb. But please remember, we have always seen them placed on the circle absorber rather than close to the patient. Inlet should be between the absorber and the inspiratory valve. APL valve should be immediately before the absorber to conserve absorption capacity, minimize venting of fresh gas. Reservoir bag should be located in the respiratory limb so that resistance to exhalation is decreased. Now, let us see some semi-open breathing systems, as I showed you that day, how we were using it. I think I discussed this in detail last time, so I did not go into detail. This is what I want to say. This is called plenum vaporizer. Now, why plenum? Can you see here, whenever the gases enter, okay, the gas enters like this. It can either go through bypass like this, okay, or here I have used a plunger, okay, I'm putting plunger down and down and down. When plunger is absolutely down, you can see gases bubble through it, okay. Now this bypass system is such, here, part of it, they go like this, okay. And depending on how my setting is, partly they go here and partly they go here, okay. So it is such a narrow passage, so resistance is very high. That's why you have to supply gases under pressure. Say, for example, from flow meter, you supply gases here. But if patient has to draw in gases from here, it is very difficult because inspiratory resistance will be very high for him to draw in liquid anesthetic agent by his inspiratory efforts. Even if you want to control breathing, you have to put in so much of high pressure for ventilation because the gases have to go through the vaporizer, pump through the vaporizer. So this system, they are called all vaporizer, means trilene bottle, ether bottle, your Flowtech Mark II, all tech vaporizers, they are all plenum vaporizers. They cannot be used as draw. Now that day I showed you Goldman vaporizers, okay? So flow rate in liters per minute. Mark II, Goldman has Mark II, Mark III, Mark IV. However, Mark II has been studied in detail. So the drum position is on 1, 2, 3 and on position. And if the flow rate varies, say 2 liters, 8 liters, 30 liters, you can copy this table. So maximum concentration that you can give is at 8 liters, 3%. Okay. At 30 and 2 liters, maximum is 1.5%. This is what you have to remember. So 8 liters flow, you can vary your concentration from 0.1 to 3%. Otherwise, it is 0.1 to 1.5. Now, factors that affect vaporization. Volatility of the liquid, amount of liquid, temperature of the liquid, flow rate of the gases, the temperature of the gases flowing over the liquid agent, the area of contact between gas and liquid, and the shape and volume of the space above the liquid. So these are the factors that affect rate of vaporization in a vaporizer. So here are drawer vaporizers. Can you see this is trilene bottle? It is called a Rouse trilene bottle. These are called OMV. They are available for halothane, isofluorine, and methoxyfluorine. Here it's written as halothane. Here it's written as trilene. It is also available for methoxyfluorine. Goldman is generally used for halothane. So these are drawer vaporizers which can be kept in your exam. So what is a drawer? Patient's effort can draw in gases through it, whereas here fresh gas flow is required. Negative pressure downstream of vaporizer, whereas here positive pressure upstream of vaporizer. Flow rate highly variable. Flow rates as per flow meter setting. Very low resistance to flow, very high resistance to flow. Flow splitting valve design is important, whereas here various designs are available. Can be used as VOC or VIC. It can be used only as VOC. So these are the difference between drawer and plenum at a gross level. Of course, there are many differences. EMO, this is a drawer vaporizer. Can you see here, the patient can draw in gases easily from this. This is Oxford miniature vaporizer. Okay. Again, I showed you it can be used for halothane. Various dial settings are available for trilene and methoxyfluorine. This is how you use. This is your EMO. It can be used with bellows. You can see here EMO used with ambu bag. Now you can see here this is Oxford inflating bellows and this is Penlon bellows. Penlon bellows, you have to use a non-rebreathing valve whenever you are using. Oxford inflating bellows, you can use head ring valve, but if you want to use a non-rebreathing valve, you have to paralyze the valve towards the patient by using magnet. You can see magnets are always provided with Oxford inflating bellows. So this is Goldman connected to bellows. Here is your EMO connected to bellows. Now drawer vaporizer, can you see here, can be used as a plenum vaporizer. But plenum cannot be used as a drawer vaporizer as VOC and VIC. You can see another drawer used as a plenum vaporizer. Now in exams, Flowtech Mark II and Mark III are kept. There are various designs. The most important thing in Mark II compared to Mark III is that it is temperature compensated, but it is not flow compensated. At lower flow rates, it gives you higher concentration. You can see flow rate is less than 2 liters, your concentration keeps varying. And invariably, you get higher concentration of gases compared to what you are setting. Here are dial settings. So this chart is generally kept in the exam. And if you are given a flow tech mark 2, this is the most important thing that you have to talk about. I think that completes my lecture. If Kalpana has to say anything, thank you. Kalpana.
Madam, do you think we have time to just go through those slides, or I think we've covered everything from the instruments PDF that we have?
Yes, yes.
So I don't think we need to go through them again, because I think most of the things we have covered up. Means actually all of them we have covered up. So then there is.
You want me to see the slides? I can tell you if you have missed something. Yeah, I can tell you.
I'll just.
No, I'll tell you now. I have this figure in front of me.
Madam, you only share your screen and show it, na, then, so I don't have to reshare.
I don't have it on this screen.
Okay.
No problem. We had that day covered up to 36 equipment, right?
Yeah.
So I'll tell you what all is remaining. See, Schimmelbusch mask we covered. We had ethyl chloride spray, Bellamy Gardner bottle. Can you share that?
But just 1 minute. Madam, just give me 1 minute. I'll just do that sharing.
Then you have to talk about your PAC catheter. Then, those flow track, pressure bag, neuromuscular monitor, and then the rest all I covered. Okay.
Vandana, excellent talk. You covered the topic.
Thank you, madam.
Nowadays, we don't meet. There's no physical meeting.
Yeah. Because no ISA meetings are taking place. No?
I know.
Now everything is online.
Absolutely.
It is more convenient, people can attend.
Madam, now can you see?
Yeah, I can see.
Everybody can see.
This I covered. See, this is one is Schimmelbusch and one is Yankauer. Okay, Yankauer has a port for oxygen. Can you see here? You can provide oxygen here. Of course, it will dilute your gases, but you can increase the oxygen concentration. And this can be used as a semi-open or open system, depending on whether you are. This, does not fit to the patient's face well. So invariably, it is it's open system. This can fit to the patient's face, facial contours, Schimmelbusch. So you can convert it into semi-open. And both you have to put in gauze space. Here what happens is this wire frame provides heat, so patient goes faster. Whereas Schimmelbusch is no these wires. I discussed this in the open system. Now, ethyl chloride spray, this is something I think you have to read ethyl chloride from the book, but its boiling point is 12.5. So it is always, at a high pressure. So it is kept in such a bottle. Whenever you press, a spray comes out. So you spray this on the gauze pills. The whole idea of using ethyl chloride first before ether is that patient goes faster. Induction is faster. If you use only ether directly, it is highly irritant. This has a sweet smell, patient can tolerate it well and can go under faster. And at particular stage, I don't remember exactly which stage you switch over to ether. I think Madam Dhaigude can tell which stage you switch over to ether from ethyl chloride. Stages of anesthesia, 1, 2. I think stage 2, phase 1 or 2, you switch over to ether. Where, patient starts breathing regularly.
Asleep.
Asleep. You see eyelash reflex. One, it is asleep, you switch over to ether. And ether you will be pouring. Can you show the next slide? This is Bellamy Gardner bottle. Okay, so what happens, one end dips inside and one is up to here. So this will draw in air. Okay, this will allow air because you are holding the bottle upside down. So one which is a short limb from which you provide ether drop by drop. And the long limb, it is drawing in air because it is at the tip of the bottle, down below. So you hold it upside down, this will draw in air inside and ether drop will come out. So you have to keep on dropping here on the Schimmelbusch mask. I think this is covered with gauze pieces, you can see, or it is inside a plastic bag, I don't know. It is covered with gauze pieces, okay? So you drop ether drop by drop here. After using your ethyl chloride, when patient goes into a certain phase, you drop it. And once patient is completely relaxed, you can intubate and put him on. Next, is there this thing, AM bottle or a next one? No, that bottle is missing, you know. AM, I mean the chloroform bottle which we dealt right in the beginning, you know, you connect with that bottle and patient breathes spontaneously. This Mark T, Mark 2, Mark 3 and all I told you what all to read. Generally, this is these are kept in the exam. And you can see, you know, depending on the dials, you know, then whether the wicks are dipping it in the vaporizing chamber or they are not dipping into the vaporizing chamber, then whether they are flow compensated, flow and temperature compensated, flow compensation to what extent, all that is what we are supposed to talk. Okay. Next. Yeah, this is your
I'm going to take a detailed class on CVP and pulmonary artery catheter, but this is a pulmonary artery catheter which is used to monitor the PA pressures of a patient, especially in complex congenital cases, patients in shock, patients who are receiving high amount of volume shifts, and patients with any of structural heart disease. The PA catheters comes. There are three types. One of them which is available is a plain PA catheter. The one which you're seeing right now, this is the PA catheter with a cardiac output. So what you're seeing, this blue thing gets attached to the machine. The machine is, this is a Vigilio monitor to which it gets attached. And this will tell us the cardiac output. It has got these three ports over here. This is the cardiac output port. Through one of the ports, you inject the saline. And through the other port is used for giving any of the medications like inotropes or something. If you want to give, you can give through that. I'm sorry, but here you cannot see the markings well. It has got a balloon tip catheter. The balloon capacity is around 1.2 to 1.5 centimeter of cc's of water, sorry. And it has got a marking. So the first dark, thick band is a 10 centimeter mark. Then the second 20 centimeter mark will have two dark, thick marks. Then third one will have 3 marks. So every time 10, 20, 30, generally the PA catheter in an average adult Indian male will reach between 35 to 45 centimeters. You will reach the PA line. And of course, the positioning of this catheter is generally done by knowing at what level you have gone in. Number 2, by also having the pressure waveforms, because you are attaching this to your pressure waveform that we generally have. And you can also do it CM guided. So this is your PA catheter. This is your Vigilio cardiac output monitor, which tells us the cardiac output of the patient along with systemic vascular resistance and the pulmonary vascular resistance. On the side of it, what you're seeing is an introflex. I have this whole thing with me and I will show you the assembly when I take a class next. So when you're putting in this PA catheter, remember there is a sheath through which you pass the PA catheter. This can be passed to the jugular. It can be also passed to the femoral. Whenever you're passing a PA catheter, please, you have to see to it that the difference in the French is at least 1.5 to 2 French difference. So if I'm putting in an 8 French neck sheath, my PA catheter can be 7.5 French or 7 French. Because remember, you are passing in your PA catheter through the introflex, that is through the introducer kit. And you should be able to move your catheter. The movement should be better so that there is no friction. Hence, there should be a difference of at least 1.5 to 2 French. Somebody was going to speak on this pressure bag, but you all know that this pressure bag is basically used for a fast, if you want to give fast infusions for any patient. It is also used for monitoring the arterial and the central venous pressure lines, where you put a pressure on a high bag, where you put a normal saline with heparin on a high bag system and at around at least 300 millimeters of mercury. So a high pressure is created. The pressure in the pressure bag, it damps the disc, a small disc which is there in the arterial transducer. So it damps that, it keeps the disc down. And that is how when you do a square wave test in your arterial line, you can make out whether it is adequately damped, under damped or over damped. Again, this is within this capacity. I will not be able to tell you this, but I will tell you when I take a class next. Who was going to speak on the neuromuscular monitor? Sanket, were you going to speak?
Yeah, madam.
Please speak, na.
So it is PNS, peripheral nerve stimulator, and it is used to monitor the degree of neuromuscular blockade. It is a battery operated device, and the stimulus which is displayed there is a monophasic square wave type. The most common nerve we monitor is ulnar nerve, and we look for the adductor pollicis muscle stimulation. Also, we can monitor facial nerve, common peroneal nerve, and the posterior tibial nerve. So usually we place the two surface electrode like our regular small ECG electrode over the nerve and connect via leads to the nerve stimulator. So negative electrode, which is black in color, it is placed directly over the nerve, and the positive electrode, which is red, is placed along the proximal course of the nerve to avoid the direct muscle stimulation. And the distance between the two electrodes should be at least 2 centimeters. And we can select various pattern of electrical impulses such as single twitch, train of 4, tetany, and the double burst stimulator. So in case of train of 4, we give 4 supramaximal stimulus over 2 seconds. And supramaximal, it is 2 to 3 times more than the threshold current. So in case of the ulnar nerve, we give 40 to 60 milliampere of current. And we look for the monophasic square wave, which is displayed on PNS. We can also look for the muscle contraction visually, and we can also palpate it. In case of non-depolarizing muscle relaxants, we can see the twitches, they progressively fade. And in case of the depolarizing muscle relaxants, the fade pattern is not seen. So that's how we differentiate between non-depolarizing muscle relaxant and the depolarizing muscle relaxant using the peripheral nerve stimulator.
Good, Sanket.
Yeah, it's okay. And you know what? Generally, what is asked is about TOF and all those things rather than the
TOF,
monitor per se.
monitoring. Madam, you have covered these. Madam, just one more thing. This ladle valve with a relief valve. So I think.
Yeah, this is a pediatric ladle valve. Yeah, can you show the? This is pediatric ladle valve. Okay. It has a port here so that excessive pressures can be released from here. Okay. So generally, this is used for pediatric cases.
This all we have covered, madam. So I'm just going ahead.
Covered. Yeah.
Garima?
Yes, ma'am.
Yeah. Can you just talk a bit about this LMA? This is an intubating LMA. Did I not give you LMA? Yeah.
Yes, ma'am. This is an intubating LMA, also known as LMA fast track. It is. It has a silicone cuff which is placed distally, and it has a inbuilt rigid steel rod and a tube to guide the endotracheal tube to pass, and it has its own endotracheal tube which has multiple rings on it, and it is used in emergency situations as an rescue airway device, or in case of anticipated or unanticipated difficult intubation. It has a cuff and a pilot balloon, and it has a various number of sizes, and the volume that we and the air that we inject is dependent on the weight of the patient.
And Garima, remember that the tube which they give is basically a reinforced flexometallic tube.
Yes.
Like your flexometallic tube, because it has to pass through the curve and you don't want it to kink, correct?
Yes,
and if I'm not mistaken, a new company has come out in which once you have passed in the tube, the LMA can be peeled off. The outside LMA can be peeled off. So that whole action of putting in the tube and then removing the LMA is not there. I couldn't get a picture of it, but I think that has just come in the market. So if I see something, I'll let you know. Madam, you want to add anything?
It's okay. Because there are too many things to be covered.
Covered, yeah. Anything important we are missing out, madam?
You all are using LMA more than me, so you will know it.
Okay,
Because
okay.
I retired in 2009.
Okay. Garima, would you like to just go ahead and enumerate different types? Unfortunately, we don't have the secondary
Yes,
LMAs
ma'am.
in
Right
the
now, what
pictures.
you are showing is iGel.
Hmm.
iGel, the difference between iGel and the other LMAs is that it doesn't have a cup. It is made up of a material which is thermo-elastic material, which automatically takes the shape of the oral cavity when it goes inside. And it doesn't have a gastric port, ma'am, separately, iGel.
So
And
this yet falls into the first generation. In the second
yes,
generation,
first
all
one,
of them you have the
gastric port.
DLTN through which the Riles tube can be passed. And the study has shown that procedures more than 3.5 to 4 hours, it is better to have a DLT so that you do not have so the gastric volume generally is not built up and you do not have any chances of aspiration or gastric this thing coming out.
Yes.
We should have kept a Procil LMA here, which I think was a mistake. We'll do it once again. Anybody, madam, on combined spinal epidural, anybody would like to speak? Mushir? Mushir, are you there? Mushir, Dinesh, anybody just speak, no?
Ma'am, this is a set of combined spinal epidural. It has a two-His needle. It is available in various sizes. It is available as 16 gauge or 18 gauge. And the needle has, and ma'am, along with it, there is a spinal needle. So through uh, needle in needle technique, through that technique, we can give the spinal subarachnoid block through it. And it has a syringe through which LOR, loss of resistance, can be felt. So there are various techniques of seeing the loss of resistance. What we do usually is we inject air and we just feel for the loss of resistance. And on the hub, it has a hub, ma'am, to secure the it has a hub for securing it, and over it, it has various serrations. So when we give our spinal through it, we can see the number at which it is going. And along with it, there is a filter and a epidural uh,
There's another method of the loss of resistance in which that small bubble is there. It was just put on our group, the newer method which has just come. Garima? I think Dr. Kiran Chadda had put it on the group, right? A newer method of this with loss of resistance technique where that small bubble is there and once you enter the epidural, the bubble comes down. Like a small rotating ball was there and then you pass in. Just to remind you that there is this thing.
Yes.
Another is hanging drop method.
Hanging drop method, yes.
Yeah, and I want to ask, supposing you do not have this set and you want to give combined spinal epidural, how will you give? Can you give?
Garima, please answer.
Yes, ma'am. Without this set, if we have to give combined spinal epidural.
Yeah.
No,
How will you
ma'am,
give?
I don't.
Sorry?
You have to give spinal and you have to give epidural. Now the question is whether you will give
Achha,
spinal first
separately.
or epidural first.
Yes. So, ma'am, we'll give epidural first. We'll secure the catheter, epidural catheter, and on the lower level, we'll give spinal block.
Correct. If your epidural catheter is going up, you will give on the lower level, right?
Yes, to avoid injury. Yes.
Yes, correct. Yeah, correct.
Okay, Dinesh, are you there?
Yes, ma'am.
Can you speak? What is this?
This is the central venous pressure set, ma'am. It contains the 18 gauge locator needle, the guide wire, the cannula, dilator, and the blade, and the fixator. So there are In the cannula, there are 3 ports. One is of 14 gauge and other 2 are the 16 gauge. And there are various approaches of the for taking the central venous catheter, ma'am. The first one is the central approach. The other one is the anterior approach, then posterior approach, and the supraclavicular approach. The most commonly used approach is the central approach with anatomical landmarks from the apex of the triangle formed by the clavicular and the sternal head of the sternocleidomastoid muscle. The needle is to be aimed in the caudal and lateral direction towards the ipsilateral nipple. The most commonly we prefer the right-sided IGV because the left-sided IGV on the left-sided the apex of the lung is higher than the right side, and the thoracic duct is proximal to the left IGV. So the chances of pneumothorax and thoracic duct perforations are more in the left side.
And when you are putting the CVP, how will you play? Can you just go through the procedure on how a CVP line is being placed, Dinesh? Quickly.
Yes, so first we position the patient and we attach the pulse oximeter and the ECG leads to the patient. We will remove the pillow and turn the head towards the opposite side. Then patient is positioned in the 15-degree tenderloin position with a wedge of 6 to 10 inches below the shoulder of the patient, and head rings to be removed. Under the strict aseptic conditions, painting and dripping done, and the landmarks are rechecked with the patient to ask to raise the head. Then with the finder needle of 22 gauge, with the finder needle of 22 gauge, we will go with the whatever the site we have marked with the central approach, that is apex of the triangle formed by the clavicular and sternal head of the sternocleidomastoid muscle. Once we get the clear venous flow, we will introduce the locator needle, and through that locator needle, we will if we will get the free flow of venous blood, then we will push the guide wire, and after that we will put the dilator. If there is resistance while putting the dilator, we will make a nick over the skin, and then we will introduce the dilator. And after that, we will push over the cannula through the guide wire, and we will observe the we will push till there is an observe in the ECG if there is any arrhythmias are there. Then after that, we will confirm the reaspiration of the blood from all 3 ports, and then we will fix the skin.
Supposing if your patient is very fat and the neck is also very fat, obese patient with a BMI very high, is there any other method you tried a couple of times? Will you use help of something else? Any point of care?
I will use ultrasound guided IGV cannulation.
Yeah. So can you just tell me briefly how an artery and a vein differs in an ultrasound?
Yes, ma'am. First, we will position the patient as I have described earlier, and then we will put the probe on the apex of the triangle of this clavicular and sternocleidomastoid. Then we can see there we will press the probe little bit. If it is artery, then it will not compress. If it is the vein, then it is compressible.
What else?
Ma'am, we can put Doppler and see for the color.
That's perfect. But just like that, when you have just put in, which will be spherical, which will be oval?
Ma'am, the
Ma'am, the
arteries will show
spherical
the
thing will be
pulsations.
artery, and the oval will be the vein.
And when you, supposing you are asking the patient to take a deep breath, or you give a head load to the patient, will you see a change in any of them between the artery and the vein? These are basic things, no?
There will
The
be change
vein
in
will-
the vein,
Correct.
engorged.
Engorgement of the vein. You will see that. Okay. Good. This is again a nerve stimulator for a PNS. Shweta, are you going to talk on cannulas?
Yes, ma'am. So the picture is show. We can see various types of intravenous cannula. So as the name suggests, these cannulas are inserted into the vein to provide a peripheral intravenous access. So they come in different sizes at 26, 24, 22, 20, 18, 16, and 14. These are color coded. So they range from violet, yellow, blue, pink, gray, green, gray, and orange at increasing sizes respectively. So as the maximum flow rate through a cannula that is proportional to its diameter, the smaller the gauge, the higher will be the flow rate. So we can see the 14 gauge orange kind of cannula will provide a flow rate of 240 ml per minute. 18 gauge green color cannula, it will provide a flow rate of 90 ml per minute, and a 20 gauge pink cannula will give a flow rate of around 60 ml per minute. And a blue gauge 22 number cannula will give a flow rate of 36 ml per minute.
What is the material which is made of? Shweta, what is the material that this is made out of? Are you there with me?
Yes, ma'am. So the material is a polyurethane thermoplastic material, so which is highly biocompatible, and it enables the cannula to remain in place for a prolonged period.
And when you are putting in, you have to look after, how will you look after this basic IV cannula, and what are the complications that you can face?
Ma'am, the complications can be like pain, ecchymosis, they can be double punctures and tissue cannulas. So there will be some less common complications like a nerve damage, arterial puncture, thrombophlebitis, and tissue necrosis. So as a guide, the cannula should be changed for every 24 hours. Sorry, for every 72 hours, I'm sorry.
I think, madam, we have finished all these. Rest all we have finished today from the 65 that we had kept. So I think we should be done by today for today. I think students, I hope you all are happy with today's whatever we've covered up with all the instruments, and whatever madam had said. I've taken some snapshots for you all, which I will send it on your academic group right away. We'll now meet maybe next week with something else. I'll talk to you within the week. We are yet concentrating on the exam going students. So we are yet not going to start off with the other batch. So we'll continue with the exam going students. Practical type of thing, X-ray test is remaining. So we'll do that. If there's anything else you all need, you can please reach out to me and we can arrange some lectures or any other thing that you require. Madam, Vandana madam, I thank you so much.
Sure.
For spending the Sunday morning with us, and even for being with us
I
on
thank
that
you
day.
For giving me a chance.
No, madam.
I thank you for giving me a chance.
No, don't say like that, madam.
Last year I could not do it.
Yes.
Out of the way you have come and given the lecture.
Yes, madam. So nice
We
of
had
you.
planned this last year, but then Kalpana knows what happened.
Yes. So, madam, I'll be in touch with you for the next batch now, which has come in. Yeah, sure. Okay, madam. Have a nice Sunday. Thank you so much.
Thank you.
Daigude madam, thank you so much for joining us. And friends, Daigude madam is now going away till July. She is not there. So I think the pediatric madam, once you come back, we will start pediatric for the new batch. Yeah. Okay.
Yes, definitely.
Okay, everybody, enjoy your Sunday. Sorry to pull you out early morning. Bye.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you.